posterior on the right, but you got to be careful. Carefully palpate to make sure nothing contradicts that. Okay. Then do this, and if it doesn't move on the right, then the right is probably posterior. And if the facial asymmetry has the mandible off to the left, then you've got quite a few things saying it's posterior on the right. So all you got to do, and you don't do any lateral to medial on this, you set up there right where you know the posterior arch and the lateral mass are, and just hit it like that to take out the rotation. Okay, and the laterality will usually resolve itself. Now at the same time, sit up. Posterior on the right, and you like to do sitting moves. Just come here, get the contact on the atlas, side bend to contact. In this case, you hold the head, because you're adjusting the atlas to the occiput, not C2 to C3. Okay, and you got to hold the head still, and just hit it to take out the rotation, and the laterality will correct on its own. Okay, so the last move, which is actually, of course, the easiest move is just that bilateral cervical syndrome thing, which I'm going to get asked. You should just know that. That's part of the regular curriculum from week 3 or quarter 3. Turn over. But this is a specific version of that. And of course, anytime you have a prone cervical, with or without a drop, it's a modified cervical break. Okay, now you're not concerned about audibles. Okay, it's amazing how you guys cannot lie straight on a table. Okay, so if it's transverse, it's posterior on the right. So that's 2 of the 3 moves. Okay, then so it's posterior on the right. I set the drop piece. Scoot down a little bit. I think your shoulders are the head piece. Not too far. Okay. All right. And get it to where it's going to drop pretty easy. Now again, as soon as you can develop a mental image of what's underneath your contacts, everything works so much better. Okay. So I'm recommending that you go to the mastoid and put your finger in front and in back in case you come down too heavy and you can feel this transverse coming this way and it goes too far. Okay. So this is just, kind of a monitoring, because if you do this too hard, it could be posterior on the right, and after you're done, it's posterior on the left. And then it'll get some weird symptoms. Okay? So you set this drop to where it's ready to fall. Okay? Put your fingers there. So then you can see, I can see that lateral mass as clear as I can see the hair on his head. Okay? And a little side bend, and it's P to A, a little S to I. Go down like that, and that is a more specific version of this one. This one is just you're going to catch it no matter what side it's on. This one's when you know the side of rotation. Okay, so I'll ask you to do Atlas modified rotary brake, Atlas rotary brake, or Atlas modified cervical brake. Okay, and I'm probably going to put together something to test your ability to interpret the examinations and get a listing. Okay, go ahead and turn over again. Now, here's the other dilemma, and there have been an endless number of students who found this out the hard way. That if you go up to the upper cervical region and you indiscriminately take an asymptomatic person and on skimpy findings do something to get an audible, and all of a sudden they've got headaches or they've got other weird symptoms. Okay? So you better make sure, however you're going to do it, like Gonstead, and it's his listings, PS, LS, LP, and all those, he would say get them off an x-ray. Okay? Now, I never did manipulations in the occiput, okay? Because, my whole life has been Atlas. But I think they tend to work, especially when the leg is pulled up 1/4 of an inch and they have a headache. Once you release it, the occiput's going to tend to drop onto the atlas on its own. Okay? But for the classic Gonstead, how's he looking?
Is he a little short on the right?
Yeah, but his legs, see the distance here?
Just pulling them together.
Yeah. Put him in the middle and that gets rid of that. So you go that way, that one's short. If you go that way, that one's short. That's why you guys just start learning to lay in the middle of the table.
I think it's still a little short on the right?
Yeah, but that's nothing. That is nothing.
Ain't nothing but a
Multiply that by 5 or 7, and that's why you guys are. If you get a high-low and you maybe somehow you got a bunch of patients come in to see you somehow, you come in, you put them on the high-low and they go down like that, and you're gonna go, I don't even have to touch the feet. And you'll just see that thing drawn up so far, okay, on 4 out of 5 patients, that it's not gonna be an issue. I think part of what's going on is he needs an ankle adjustment. He's got some oddities. This is talus. Look at that hanging down. That talus is way anterior. Unless do you clear that stuff out of your back pockets? Yeah. But this is a real solid indicator of talus.
So would you
It
adjust
doesn't
that?
matter what you do it. You can do it to start.
But you have to address it, right?
Yeah, I would. And patients feel better after you do it. Okay.
What do you like for a talus? Do you like the standard?
I like the way I do it.
All right. Let's have a look.
Okay. Which is to grab high and low, leave the joint in its neutral posture, just go straight out like that. Okay. Now, if it doesn't totally go, and we don't know the history, he could have some ligamentous damage. You can go down like that to the very left. But this right here is associated with what I call collateral damage. That means you're doing some good, but you're banging joint surfaces that don't need to be banged around. So all my extremities, I leave just in their neutral joint position when I do them. I do it for the wrist, I do it for the elbow, I do it for the shoulder, do it for the knee, do it for the fibula, do it for the acetabulum. I found out, I learned all the ways that you've seen, and I always had to ice the patient after I did the extremity adjustment because I was banging the joint surfaces. So I found out if you left the joint in kind of this neutral position and just open up the joint, then you don't have to bother with that because you're not slamming joint surfaces into each other.